Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 81, Twins. When I was a child, I thought twins would be great. There were some sets of twins in the family. I had twin great aunts, identical, and it seemed fun, the idea of a lifelong buddy. I thought when I started my family I'd love to have twins. Maybe I'd get lucky. Maybe I'd only have to go through a single pregnancy to get 2 babies. Maternity leave once over. What a bonus that would be. As I started my obstetric career though, I got older and wiser. I started to understand multiple pregnancy, the ins and outs, and along with this, the thought that really, unlike many other mammals, we really were better set up for having singletons, that is, one baby at a time. The reason for saying this is that I know as an obstetrician, twins have twice the risk of stillbirth and 3 times the risk of neonatal death, compared with a singleton pregnancy. Twins are also much more likely to be premature, with 50% of twins arriving before 37 weeks and 10% before 32 weeks. On top of this, you have to add in the increased chances of just about every pregnancy-related complication and problem for the mother-to-be. So while twins seem cute and fun, and of course many twin pregnancies will be uneventful, these statistics are always in the back of my mind as I talk to and look after a family expecting twins. In the UK, about 1 in 60 pregnancies are twins. In fact, twin pregnancies are probably much more common than we think. As we've been scanning earlier and earlier in pregnancy, we sometimes see what's called a vanishing twin, a second sac, or even a fetal pole, the start of a developing baby, on a scan at 5 or 6 weeks, which may well have disappeared by 12 weeks when the standard first scan in pregnancy is performed. When people hear they're having twins, one of the first questions they ask, or people in the family may ask, is, are they identical? Non-identical twins, so-called dizygotic, happen because 2 eggs are released and fertilised at the same time. This is a bit more common in women over 35 years of age and can also run in families through the mother's line. Twins are also more common following fertility treatments that have stimulated ovulation, as it may be more likely to release more than 1 egg. And they used to be much more common after IVF if more than 1 embryo was put back at embryo transfer into the womb. But in recent years, regulation of IVF has gone back to recommending a single embryo being transferred because twins can be so complicated. Identical twins mean that a single egg was fertilised and then the resulting embryo, so-called monozygotic, split at some point during development. Depending on the timing of the split, the babies may or may not have a separate placenta and be in separate sacs of amniotic fluid. As obstetricians and midwives, we're as keen to know this information just as much as the prospective parents. And this is because the type of twins helps us know the possible complications that may arise and therefore how to tailor and adjust our antenatal care and birth. At the 12-week scan, we're therefore trying to determine what's called chorionicity. Non-identical twins and identical twins that split early will be dichorionic diamniotic twins. These are babies with 2 totally separate placentas and 2 filmy membranes each. This can be seen on the 12-week scan as a lambda sign because it looks like the Greek letter lambda. Identical twins that split later will be monochorionic diamniotic. They'll have a single placenta and chorion membrane, but 2 amniotic membranes. This means that the babies are still in separate sacs, but the membrane between them is much thinner, flimsier, and seen on the scan as the so-called T sign. Much rarer are monochorionic monoamniotic twins, 2 babies in a single sac, or those that split later still, so-called conjoined twins. If you're finding this hard to follow, there are some great illustrations on the RCOG Multiple Pregnancy Information leaflet that I've included in today's programme notes. By the 20-week scan, of course, if the babies are different sexes, it can be obvious if they're identical or not. When we've looked at the chorionicity, this will determine the care offered during the pregnancy. If you're having twins, really you want to have dichorionic diamniotic twins because these are the least complicated twins. This would be followed by monochorionic diamniotic, then monochorionic monoamniotic. But all twins will require a series of additional scans and appointments to check on the growth of the babies. And this is because the way we normally assess growth during pregnancy, measuring the mother's symphyseal fundal height, that is the size of her bump from the top of the womb that we can feel with the flat of our hand down to the pubic symphysis, is not effective at assessing growth in twin pregnancies. Partly because obviously there are 2 babies, but also because the babies may grow at different rates. So each scan will be looking at how the baby's growth compares with one another. And if there's a 20% difference or more, this can be of concern and may mean that we need to scan the babies again more frequently than we would have done otherwise. Because twins have a higher chance of complications, a couple of years ago, the new NICE National Institute of Clinical Excellence guidelines in 2019 recommended that women are cared for by a specialist twin clinic. This would be a group of midwives, obstetricians, and other health professionals who are expert in looking after twin pregnancy. This also obviously requires input from the neonatal team, who may well need to be involved in planning birth and the care of the babies. I am not one such obstetrician. I used to see twins in my clinic just because of where they lived. They were attached to me because of the postcode. We each, as a consultant, had a geographical area. But now we've moved to having a specialist twin clinic. And obviously, this can be very beneficial. After all, this is why the recommendation has been made. There's some evidence that it may improve outcomes. But the flip side of a specialist clinic is, what if a pregnancy involves more than one complication? If we're labelling a woman as a twin pregnancy, then what if she also develops diabetes? Or what if she has mental health issues and needs to come to the joint perinatal mental health clinic? What condition trumps what? So whilst specialist clinics may seem a fantastic idea, it does take a bit of teamwork and a bit of thinking through. Because I'm not a twin specialist and I'm not a fetal medicine consultant, I've struggled with thinking about how to talk about twins in this episode. So much so that I've stopped and started this episode on a number of occasions. In the end, I decided I'm probably overcomplicating things. It doesn't matter if I'm not an expert. I'm not trying to produce an encyclopedia to tell people how to care for twins and give them all the information, or provide all twin mums with an explanation of every possible thing that can happen. There are plenty of scientific articles and comprehensive guidance that you can find on the internet if you want to know every detail, every in and out. So what I'm trying to do today is just give you my perspective as a general obstetrician. One of the key things when thinking about twins is birth. Both the timing of the birth and what we call the mode of delivery, the type of birth. Advice now is to recommend timing of birth to be a bit early. For dichorionic diamniotic twins, we recommend birth around 37 weeks. The babies are mature, and we know that the risks of stillbirth increase beyond 38 weeks. For monochorionic twins, we will often recommend birth even earlier, from 36 weeks. Sometimes, obviously, this timing is irrelevant. I've already mentioned twins are quite often preterm. A woman may have gone into spontaneous labour. If so, not a problem. But if not, we need to have significant conversations about induction of labour or caesarean section. And of course, as with everything in obstetrics, or anything in medicine for that matter, the woman in front of us, they have a choice. They don't have to take our advice. I've cared for women pregnant with twins who want to go on, not only to 38 or 39 weeks, but beyond their due date, even to 41 weeks. And this is tough, really tough. I don't know why I find it so much harder. Maybe because the perinatal mortality is significantly higher. There have been times not that long ago where the perinatal mortality for twins was 11 per 1,000. That's 1 in 100. That's a pretty high chance of a baby dying. And it's hard because it isn't that I'm completely risk averse, and it isn't that I don't respect the person's autonomy. It's the fact that I have seen the consequences. I've seen those statistics. I've witnessed twin pregnancies where things may have gone horribly wrong. And however much you try to put those things out of your mind when you're trying to discuss things with a woman is difficult. I don't want to be biased, and I need to acknowledge that my experiences shape the way I feel about things and the way I might recommend things, but it can be hard to ignore and put to one side. So that's the timing issue. What about mode of delivery? This is vaginal birth versus caesarean section. It's commonly recommended that monochorionic diamniotic twins would be better born by caesarean. This is partly because of the fact that you can have an acute twin-to-twin transfusion, because monochorionic diamniotic twins will share a placenta and may have blood vessels in common. Minimising the timing between the birth of the two twins by having them born at caesarean minimises the risk of this acute complication occurring. It's not to say all monochorionic diamniotic twins should be born by caesarean, but it's definitely something that we need to seriously consider. What about dichorionic diamniotic? These are our least risky twins. If you have a twin pregnancy, that's ideally what you want to have. One of the key things about twin birth is which way up the babies are. Because there are two babies, there's a higher chance of one of them being in a more complicated position. So when we're talking about vaginal birth versus caesarean, for DCDA, dichorionic diamniotic twins, the first key question is, which way up is the first baby? Twin 1. The baby that's nearer the cervix, nearer the neck of the womb, is it head down? Is it bottom down? Is it transverse? If the first baby is bottom down or transverse, we will recommend a caesarean section. Yes, I have had the occasional woman try to give birth to babies that were breech, both bottom down. I have to say, not with success. The key determinant of successful vaginal birth is the first baby needs to be head down. It doesn't particularly matter which way round the second baby is, the baby that's higher up in the womb, further away from the neck of the womb. And this is because this baby will change position significantly once that first baby is born. Many couples will opt for a caesarean birth for twins, regardless of which way up the babies are. And that's because an emergency caesarean birth is more common with twins. After all, there are two babies that could get stressed by labour. There are two babies that could be in the wrong position. And if you haven't gone into labour naturally, you're facing an induction process, which may or may not be successful, depending on how your body responds to the hormones that we're giving. We worry about the risks of emergency caesarean. It's less safe than a planned caesarean, so it's not surprising that some women will feel that a planned caesarean is their best option when they know the chances of an emergency caesarean are higher. But there was actually a really lovely study, and I've included a link to an animation of the results in the programme notes. This study looked at twin birth. If the first baby was head down for DCDA, remember babies in two sacs, dichorionic diamniotic twins, what was better? Planning a vaginal birth or planning a caesarean? And actually it found that the outcomes for both the mother and the babies were the same. So there was no disadvantage of planning a vaginal birth and having an emergency caesarean over planning a caesarean birth in the first place. Therefore, whilst families do have a choice about how their twins are born, on the whole, if the first baby is head down and they're dichorionic diamniotic twins in two sacs, we generally recommend vaginal birth. Vaginal birth of twins can be fabulous. If both babies are head down, it can be incredibly straightforward. It can be calm. It can be a lovely, intimate birth, despite having probably significant numbers of staff in a room. But when you're having a vaginal birth of twins, there are some key things that we will recommend. And again, we will be recommending them because we've seen when things have gone wrong. When the first baby is born, we will normally hold the second baby in a good position, a so-called longitudinal lie, vertically in the woman's womb. And this is because that second baby suddenly has tons of space in which to move around. So one of us will firmly hold that baby in place. And we will often suggest starting a hormone drip to make sure the contractions continue going. We're aiming to get that second baby born within half an hour of the first baby. And that's not just because we're clock watchers. It's because we're worrying about separation of the placenta. Will the placenta start to come away because the body thinks it's already done its job? If the second baby's heartbeat is stable, of course we can wait longer for that second birth, but we need to be monitoring it closely during the time interval between the birth of the first and second babies. And we need to make sure that that second baby is making progress. It's making its way into the world. So we will stabilise and hold that second baby, and we'll encourage the mother to push until that second baby comes down into her pelvis. It doesn't especially matter if it's bottom down or head down. The most important thing is that the baby is coming down into the pelvis, and when it does, we can break the second bag of waters round the baby with a little hook called an amni hook when the woman is having a contraction, and then that second baby will come down, stay in the pelvis and not move up out again. At that point, we can let go of the woman's abdomen because we know that baby's not going to spin off anywhere. This may sound quite restrictive, but I can tell you from experience that this is the way to calmly manage a twin birth. For many women having twins, the thing they are most fearful of is having one baby vaginally and then having a caesarean for the second baby. The rates of this happening vary a little bit, but can be around 2%. No woman wants to have a caesarean and vaginal stitches to recover from at the same time. And really, this rare event should be even rarer, because on at least some of the occasions I've seen this caesarean for a second twin happen, it's because we haven't managed things well. Sometimes labour is fast and furious. I can remember being called as a registrar to a twin birth. The first baby had come out unexpectedly quickly. The team had not been ready. No one had stabilised that second baby. So it had spun off to a transverse position. Now, in itself, a transverse position, lying horizontally across the womb, isn't actually a disaster if the waters haven't broken. Because the baby's still got that lovely pool of water in which you can move it. You can push it round. But unfortunately, what had happened was someone inexperienced hadn't realised the baby was transverse, and because they were attempting to get the second baby down into the pelvis, they'd broken the woman's waters. So once you've broken the waters, you haven't got that lovely fluid in which to manoeuvre the baby. So the waters were broken, the baby was lying across the womb, so impossible to come down into the pelvis, and we had to rush off to theatre for a caesarean. When I was training and I was managing the birth of the second twin, I was actually taught that if the second twin was breech, bottom down, it was easier than if it was head down. And to some extent, that's still true. Because if the bottom doesn't come down into the pelvis, you can do a procedure called a breech extraction. This is when you reach in to find one of the baby's feet. It's important you definitely know you have a foot, and you can check that by feeling for the heel, because if you have an arm, then that's disastrous for the delivery. It doesn't work. But if you have a foot or feet, you can feel them, you can find them through the unbroken waters, particularly if you scan to identify which side the limbs are. You can feel that foot and then pull it down. And as you pull it down, the waters often break, and then you've got the legs and the bottom coming straight down, and then you can encourage the woman to push and birth her baby. But you've got those feet, you've got something to grab hold of. Whereas if the baby's head is very high up and not coming down and the waters haven't broken, it's much harder to get hold of it. It's much harder to use your hand or an instrument. We did sometimes used to use a specific sort of ventouse suction cup to get hold of that second baby and bring the head down through the cervix. And the cervix is a bit like a piece of elastic. It stretches up as the first baby comes through and then sort of pings back. So between babies, if the second baby isn't pressing down on the cervix might appear to be only 8 or 9 centimetres, less than fully dilated. But once you've brought that second baby down, it will expand up again, stretch, and let that second baby through. So breech extraction could be actually a really swift and easy way to help the woman birth that second baby. And sometimes when a second baby's heartbeat drops because there's been a bit of a gap between the birth of the first baby, often carrying on with a vaginal birth of that second baby can be quicker and simpler than having an anaesthetic and going ahead with a caesarean operation. So that fear of a caesarean for a second twin also may reflect a bit the experience of the obstetrician caring for the woman and what they feel is the quickest way to get that baby out safely. So when I talk to women antenatally, or when they're in the early stages of labour, about what I'm going to do to try and help their birth be straightforward, I try and get across to them that actually, although these things may seem like interventions, they're all performed for a reason, and hopefully they're going to make the birth go very straightforwardly. Because, let's face it, prevention is better than cure. If we can prevent that second baby spinning off into a difficult position, if we can prevent the contractions from halting, if we can keep an eye on that second baby's heartbeat and make sure it's coming down in a timely way so that we minimise the chance of the placenta separating prematurely, then twin birth can be beautiful. And it may appear to some students or families, gosh, what was all the fuss about? That was all very easy. That was all very straightforward. Well, that's because we were anticipating and helping things along. When we're thinking about twin birth, there are some other decisions that need to be made. Do we go to theatre or not? The rationale for going to theatre is sometimes just simply more space. A birth room on the labour ward is significantly smaller usually, and for a twin birth you're going to need a large number of people. You're going to need paediatricians, obstetricians, midwives, anaesthetists. It's going to get a little crowded, and that's before the equipment you need. So you'll need 2 resuscitaires in case the babies need help. You're going to need a scan machine so you can track that second baby and monitor its heart rate. You're going to need instruments in case you need to assist the birth of that second baby. A little hook to break the waters. And then you're also going to need things to prevent bleeding problems afterwards, which are also a bit more likely in a twin birth. So sometimes people go to theatre. It's much more spacious. You can have everybody you need. And of course, you're in the right place already. If it does turn out that this is one of those situations where you actually need to do a caesarean for that second baby. And obstetricians will often choose to go to theatre if the second baby is breech, if they think that it may be a little bit more complicated, or they may need to do some manoeuvres to help that second baby birth. The problem with theatre is it's a very bright, somewhat clinical environment. Sometimes I almost feel it causes stage fright. The contractions stop. The woman might feel a little bit on display. It's disrupted everything by moving her. And in practical terms, when are we going to move her? Are we going to move her just as she starts to push, in which case she could be in theatre for an hour or more? Or are we going to move her when that first baby, when the head becomes visible? In which case we're disrupting things literally just at the moment she's about to give birth. But if we move too early, then we can block our obstetric theatre that we might need for other emergency cases for a significant amount of time. And with the decision to go to theatre or not go to theatre also comes the decision, what pain relief? Well, a twin mother is entitled to any form of pain relief she wants, just like any other birthing mother. Should we be suggesting that she has an epidural or even a spinal anaesthetic just on the off chance that we need to do something? Not really. But if we go to theatre, is she going to lie on a theatre table, which is not comfortable, I can assure you? It's even less comfortable than a delivery bed. And if she is, then if we're in theatre, the idea of being in theatre with no pain relief feels odd. We're not used to having women in theatre with nothing. Our anaesthetic colleagues will be asking us, do you want an epidural? Do you want a spinal? What anaesthetic do you need to help with your birth? And sometimes women are told to have an epidural because it's twins. And I don't think that's right. We have recourse to other options. We can give a pudendal block, after all, or local anaesthetic infiltration if needed. if that's what she prefers. So far, I've talked about birth in an obstetric unit, in an obstetric theatre. What about birth centre or even home birth for twins? I have had to have antenatal conversations with women about these options. Because I'm not a midwife, I haven't had to care for a woman in labour in these situations. And whilst I respect women's choices, I fear that they are making themselves vulnerable. On the whole, maternity staff do not have the experience to care for women with twins in these settings. We can put in plans. There are limitations perhaps about fetal heart monitoring in the birth centre or a twin birth in the pool. If one listens in with the handheld Doppler, which we use for listening in intermittently in labour, it just simply isn't reliable. We may listen inadvertently to the same baby twice over. And this is one of the reasons that we suggest continuous heartbeat monitoring of both babies, so that we can be sure that we are monitoring both babies and how they're coping with the stress of labour, the stress of contractions. Even in the antenatal clinic, because of the limitations of the Doppler, we will get out a portable ultrasound scan machine and scan to check both babies' heartbeats are present. And we'll do the same during labour if we're struggling to listen in and hear both babies and identify that they've clearly got different heartbeat patterns. And I'm not saying if we've never done something, we can't make a change. Of course we can. But we have to accept that when we're pushing the boundaries and doing something that staff are unfamiliar with, that adds to the chance of something unforeseen happening. These are difficult conversations to have. We don't want to scare women. We want to support them. But we also have to be honest about what we are worrying about and why and what those statistics are. I love a vaginal twin delivery. It's incredibly satisfying when things go well, and also when I can take a junior colleague through what to do and how to do it and support them and see them experience the joy of doing it right. I've done some lovely twin deliveries. And like I said, the best ones can be almost as if, what was all the fuss about? They're busy. There are lots of people. But it's joyous when those two little babies make an appearance. In lockdown, I had twin parents saying it was like having a party. They hadn't been in a room with so many people for so long. It was like a birthday celebration, the arrival of their babies, surrounded by the members of the team. Enough rambling. What's my zesty bit? I think the zesty bit is don't underestimate the challenges of twin pregnancy. Look at the recommendations from the Embrace report and the 2019 NICE guidance. Have you, in your maternity unit, implemented the recommendations and the guidance? If not, why not? What's stopping you? Have a healthy respect for twin pregnancies. If you do, they will go well. because you will be anticipating. And make sure you're having those honest conversations with families about the whys and wherefores for your recommendations. If you're pregnant with twins, think about who is looking after you and what are they recommending. Are you under the care of a specialist team? And if you're not, could you be? There are lots of wonderful resources, advice and support on the Twins Trust website, which I've included in the programme notes. Understand your choices, but understand the bigger context and why we're suggesting you do what you do. One of the things I love most about the twin team at my hospital is that both of the midwives running our twins team have had twins themselves. So they not only have their midwifery experience, years of it, but they have their own experience of their own pregnancies, births, and challenges of bringing up twins. One of the great benefits of the Twins Trust is you can tap in to other parents who have had or are having twins. Educate yourselves, be proactive, ask questions, and hopefully your pregnancy and birth will be the best start for you and your babies. I do hope you've enjoyed listening to this episode of the obspod. Feel free to contact me on Twitter at FWMaternity or at theobspod to ask me questions, give me topics for future episodes, or let me know what you think. It's absolutely fantastic when you get in touch. I really enjoy reading your comments. As usual, I've tried to include in the programme notes some extra reading about this particular topic, both for professionals working in maternity care and for pregnant women using services. I'd like to reassure you that although I'm talking about my experiences working in maternity care, I take confidentiality very seriously and do not give any personal information about any of my patients. If you've enjoyed listening, I'd love you to recommend the obspod to friends or colleagues, and please do leave me a review on whichever podcast directory you find my episodes. Many thanks for listening.